results on signal functions that have been performed and reasons for non-performance of the signal functions. So as an update, we are happy to report that regarding the trainings, all the 3 counties have included their EMOC trainings in their annual work plans 2022-2023. Uasin Gishu is yet to conduct the training, but Vihiga and Garissa have had the trainings. There's a pool of trainers who have continued to support these trainings within these counties, and they're also called upon to support trainings outside these 3 counties. And we were also working with counties to mobilize resources for establishment and equipping of the EMOC skills labs at the health facilities. We're happy to report that Garissa County Referral has renovated a skills lab, a room next to the maternity unit, which is now working as a skills lab. The LSTM contributed to some of the furniture, and the renovation was done by another partner. This is a hospital that said our priority is a skills lab, and they sought support to ensure that it's equipped and functional. Then for post-training mentorship, we are happy to report that Uasin Gishu and Vihiga have not only continued doing the mentorships, but they've expanded these mentorships beyond the LSTM focal facilities. In terms of county support towards EMOC mentorship, this has been very good. RH coordinators have continued to share reports on monthly mentorship that is conducted in each of their facilities. They've continued to compile and share with us as a partner. So that means it's continued even with minimal support or no support from LSTM. The WhatsApp groups, very active. Then counties are also committed that they would look at the periodic reflection and learning events from mentors, whereby mentors come together and just sit and reflect what is working well, what needs improvement, and how can we move it forward. Uasin Gishu was very innovative. They had a virtual one. Mentors joined virtually, and they had their reflection event. So that was very good, Uasin Gishu. Vihiga has had a physical meeting with the mentors, and it's also a way of sharing knowledge and also planning for the next steps. In terms of EMOC functionality assessment, during our in-service session, we heard that MOH is working on digitalizing the tool. So we look forward to seeing that. Ultimately, MOH would like that tool to appear on KHIS, so that when you sit in Nairobi, you're able to know if how Garissa is performing with their EMOC signal functions. Then in terms of LSTM technical support to the counties on EFA data management, in the previous KMLs, counties had requested us to support them on how to use the MOH tool. LSTM has developed reference guide on how to use the MOH EMOC functionality assessment tool. So that is done. And in terms of counties conducting EFA, counties have been able to conduct the EFA, the 3 counties, but as I mentioned, the challenge is data analysis and reports. So much as they've collected the data, they have not yet analyzed the data, except for Vihiga. Again, congratulations, Vihiga. They were able to conduct the latest report and the latest analysis and disseminated the report. When we were in Vihiga in November at the Knowledge Management and Learning event, we were told that whatever you appreciate, we'll appreciate, and whatever you do not appreciate, we'll begin to depreciate. And that was one of the reasons why we were encouraging counties to actually appreciate their outstanding staff and health facilities. Counties committed that they will do this on an annual basis, and we are happy to report that Ijara Sub-County Health Management Team conducted their award ceremony in December 2022. They recognized the best performing health facilities and the best performing healthcare providers. In a very simple way, they invited these people to their office and gave them certificates. So Kotile was the best performing health center. Congratulations, Garissa, for taking that forward. That is a simple certificate of recognition that was awarded by the sub-county management team to Kotile Health Center. The HR dashboard is a county strategy for managing staff retentions we're happy to report that the 3 counties have adopted this as a tool for managing staff retention, and we are making at EMOC-trained staff within MNH units. On a quarterly basis, this dashboard is updated to see the status of EMOC-trained staff. Where are they, if they're in MNH or they're not in MNH? And it has also been used to identify which facilities are to be targeted for trainings. So just as an update, Garissa has been championing this agenda. The RH coordinator, when she goes out to the health facilities, she's been using this opportunity to sensitize her facility managers on the importance of ensuring that EMOC-trained staff remain within the MNH units, or if they're to be transferred, there's at least people they have mentored before they are transferred. Vihiga has also used this dashboard to make decisions on staff promotions. One of the mentors who had done very well in a facility was actually promoted to become a sub-county RH coordinator, bearing in mind that she had actually mentored people in her facility who can carry on with the mentorship. Wasingishu has also, Vihiga also used it to second a mentor to one of the facilities that had an internal challenge with maintaining staff. So we see that the HR dashboard is actually not only being updated, but it's used to inform decision making. Wasingishu also has used it to inform decisions on one staff transfer. So that slide just illustrates the dashboard. Baseline was the baseline in blue was done in August, and the one in December, that is the update. And we see that Garissa has had a slight improvement in percentage of staff working in MNH units who are EMOC trained, and it's also similar across the counties. So the dashboard is in use, and it's helping. It's not sophisticated, as Lucy said yesterday. It's a simple Excel sheet. So in conclusion, as LSTM, we are confident that the counties have a level of inbuilt sustainability to be able to continue conducting EMOC trainings, facility-based mentorship, and utilization of the HR dashboards, as well as the EFA quarterly assessments. However, we continue to recommend that National MOH digitalizes the assessment tools and supports the counties in equipping of facility-based skills lab. For those of us who are in the in-service work stream, we learned from MOH that they have big plans, and they have received partnership support in order to equip skills labs, so that is good. And then we also advocate for medical schools to incorporate EMOC and advanced obstetric skills within their curriculum. Otherwise, we appreciate all our partners who have come with us this far, and not forgetting again the frontline healthcare providers. Thank you.
Yeah, so thank you very much, Irene, for that elaborate presentation on the plans for sustaining the gains so far out there in the field in terms of the in-service work. Now we give opportunity to Duncan, the chief educator, to continue where he left. Many proverbs are welcome. Thank you.
There are no hyenas in the house this afternoon. Suddenly, I can't see the presentation again. Great. Good afternoon. Sorry for wasting time, and I hope I'll not waste much time here. You know, a man who has been accused of stealing a goat cannot entertain his guests using goat meat. So I'll share some transition plan on the pre-service work. I'll give a few lessons we've learned during the implementation, and then in the transition, I'll share something around the curricular review, capacity strengthening, students teaching, equipment, and CPD work. As part of the lessons we've learned during the implementation of this work, there's really need for us to integrate teamwork for all the skilled health personnel, people who work within the maternity units without focusing on one cadre and leaving out the other. And we are talking about the clinical officers, midwives, and also the medical doctors, just as outlined, as defined by the WHO and all the other stakeholders as a skilled health personnel. It's a collection of team members for them to be able to work together for the benefit of the mother. And then while giving these updates, we should always remember to integrate between pre-service and in-service, because when there's a harmonized teaching, then there's a harmonized practice. Yesterday, we had a comment from one of us here that sometimes you receive students in the clinical environments and you are wondering where these students, whether they have been coming from, whether they have been attending a class. You see, when you receive such and you are always getting these updates, as the in-service team, what do you do to these students and to the educators? Do we just sit down and blame the pre-service guys for not being updated? So as in-service working within the facilities, when we have opportunities to get these updates, we are always attached to teaching institutions. Why not call colleagues from the teaching institutions to be part of the team receiving these updates within our institutions? Then the second aspect is around curricular reviews. One of the institutions we visited told us that this was the first time a curriculum has been reviewed and educators followed up to be sensitized on exactly what had been included and also taught on how well to deliver it. So we think this is a practice that should be integrated and continue for all other future curricular reviews. Then training alone is not sufficient to maintain competencies. I was just telling the other group in the pre-service team that Ahigot has one of the best beards in the world. But if the beard was everything, this Higot could preach. For these trainings, we pump so much into the trainings, but training alone cannot be sufficient for us to maintain these competencies. We need other systems. We need the CPD systems. We need the mentoring systems. Our educators and our practitioners need access to systems where they can be able to update their skills and competencies. And this is something we are calling, we are working together with the relevant regulators and the institutions to ensure that these are things in place for people to have the capacity, at least access to regularized capacity for improved practice. Then as we work, we should always endeavor to strengthen both the public and the private institutions, because we are all players in provision of healthcare, and we should be able to work in harmony, because when we work in harmony as private and public, it's the final woman and baby who ends up benefiting. And so as part of the sustainability plans and as part of the transition, there's the aspect of curriculum. I'm happy that for Kenya Medical Training College, this is now something within their budgets. They are able to budget and have these curricular reviews. And once we have this, there is also a plan for them at least to be updating the lecturers once they've updated this curriculum. We hope that this is a practice that can be taken up by all the other players, such that we have these regular updates on curriculum, because so many things are happening within our country, and we need a structured platform at least to legalize, to ensure such things are integrated for good practice. The second aspect regards the capacity strengthening of our educators within our institutions. A number of opportunities have been provided, including peer teaching and support, where some of them have been trained around the issues to do with peer teaching, and they can be able to support one another within the institutions. Looking at our trainings, we used to train clinical officers and nurse midwives within these mid-level training colleges, and we believe there is an opportunity that is already being witnessed in some of these colleges, where they all team up together and train these students on the same skills, such that by the time we always say, we always have these deficiencies in terms of the teaching faculty, but when the two departments team up together, we are able to achieve more within a shorter period of time. And then there's need for us to have this on-site mentoring of our educators, and I'm also happy that within the KMTC setup, there is a plan for the regional training hubs based on the former provinces, whereby at least people from a certain region will be teaming up together to just build the capacity of their educators in key skills, both teaching and also emergency obstetrics and newborn care. In terms of skills, there is need, LSTM has provided equipment to the training institutions, but there is need for us to maintain this equipment, because after they have been used, there are those wears and tears, but there is always need for us to have at least good storage and maintain a regular inventory of these equipments and functionality. And I know in some of the institutions, efforts are underway at least to have people who can support in terms of managing this skills lab. But even as we get these people on board, there's need for us to sensitize and at least take them through some training on what some of these equipment are and how well to maintain them. One time we went to an institution during our mentorship visits, and the mentor requested one of the skills lab attendant to bring us a stethoscope because it was very key for the skill he wanted to lead. Our colleague brought us a microscope after hesitating for a while. So when such things are happening, it's not like, for him he knows a scope is a scope. Whether it is a stethoscope, is a microscope, a scope is a scope. So there's need for us to sensitize and educate people on what exactly we are talking about when we have these equipments, such that we can have a harmonized practice. Then, practical teaching of students. This is an area where our educators, both from universities and also from the mid-level colleges, have had several weaknesses here. People are so good in theory, but when it comes to the practical aspects, this is where we have some deficiencies. Some of the things we have in place is that we now have equipped skills lab, and there's need for these educators to have these skills demonstrations for students before they proceed for their clinical placements in the wards. And then some of the institutions have also had student facilitators. Some students have been identified to be so good in specific skills, and these are students who are helping to train their fellow colleagues. And this is something that is also helping us to manage areas where we have insufficient faculty. And students, some of them have really commented that when they are being taught by their fellow students, it is very easy to even ask questions and strive to achieve the same competencies as their other colleagues. And then follow up on students during clinical placements. Now, it's also difficult for a lecturer to follow up students when he or herself is also not competent with the skill to be followed. And there is a very good plan for our educators to also participate in these clinical placements and practice for them to improve their skills, such that even when we go for the clinical supervision of students, then we are also updated with what is happening around. And lastly, there is the continuous professional development. As we speak, a lot goes in around training, but this is something that depends on the available funding. But then we need this system in place such that it is a sustainable system for educators to be, at least to have an opportunity to update their theoretical skills and also the practical skills, including the principles of teaching and learning for effective delivery of content to the students. And also, this will be an opportunity for people to update themselves in terms of their knowledge and practical skills in their teaching competencies. Guys, thank you so much. I wish to acknowledge our partners who've supported us to this end and all the stakeholders who have participated in ensuring that as pre-service, everything starts around pre-service before we get to in-service. And therefore, the efforts around pre-service are greatly acknowledged. Thank you so much.
Thank you very much, Duncan. The impression I get is that either there are many sages in your village, or you have too many goats, or, you know, there's always something around the goat, but we really enjoy those sayings. Yeah. So we'll go on to the last presentation on transition plans for MPDSR. It will be made by Madam Scholastica Wabwire from the Ministry of Health. Welcome, Scholar. Martin, we need your assistance. Where is the presentation?
Mbona unakataa? Singekutolea hapa nini ifanye? Asante sana. Okay, so I will take you through the transition plan for MPDSR, and so this is it, eh? Okay. So the outline is as follows, that we going to look at why we should have this transition plan and the key activities in the transition plan. We're going to look at CMD versus MPDSR and also the way forward for Kenya. So why the transition plan? Ni rewind. So why the transition plan? As you're all aware of, the FCDO-funded MNH program is coming to an end by the end of this month. And the transition plan is to inform the process of the institutionalization of MPDSR activities at the national level as well as the county level. And then it also will provide the pros and cons for the CMD and MPDSR process. So the key transition activities are as follows. Number one is handing over the National Secretariat Office to the Ministry of Health. Number two is about the monthly National MPDSR technical team meetings. There's a modality on how this will continue. And then number three is review of the retrieved and anonymized maternal death files, review and documentation of the progress in the implementation of the first CMD recommendations, integrating MPDSR activities into routine QOC framework, as well as participating in the knowledge, management, and learning events, including podcast production. So on handing over the National Secretariat to the MOH Division of Reproductive and Maternal Health, one of the requirements or one of the activities that is undertaken under that secretariat is convening the monthly MPDSR technical team meeting. And LSTM will continue to convene the monthly national MPDSR technical team meetings with the MOH. And this means they can't just off and go. The transition has to be progressive. So as they hand over, they can't just hand over everything and move. So we will continue they will convene the monthly national MPDSR technical meetings with us. And these meetings present a forum for discussing the transition plan, as well as receive updates from partners on the ongoing activities supported by partners on MPDSR. So review of retrieved and anonymized maternal death files. The Secretariat has supported training of 93 maternal death assessors from all the 47 counties. And the assessors have been taking part in the review of maternal deaths since 2015 through a series of regional workshops. The CMD report has served as an advocacy tool for the Ministry of Health at both the national and subnational level, that is the county level. And as part of the process geared towards the production of subsequent reports, the MPDSR Secretariat has retrieved the anonymized maternal death files from the 47 counties for the years 2017 through to 2020. So the maternal death files from 2017, the year 2017 has been assessed. And we need to put measures in place to facilitate the review of the remaining files, that is for 2018, 19, and 20. And these are a total of 1,483 files. So this is the status of the maternal death files retrieved and assessed since 2017 to 2020. In 2017, we were able to retrieve 575 files, and we were successful in assessing all the files. So we do not have any pending files for 2017. 2018, we retrieved 675 files. We were able to assess 452 files. The pending files here are 223. 2019, we retrieved 580 files. We have not assessed any of these files. And also for 2020, we have 680 files pending. So we have 1,483 files that are pending, and they need to be assessed. This is about over 50% of the files we collected since 2017, the 2017 files to 2020 files. So status of maternal death files retrieved and assessed, this is a continuation, is that previous experience has indicated that we only require 4 days assessors workshop to review at least 250 files or assess 250 files. And for the pending files, it will take at least 4 days assessors workshops to completely assess the remaining files. And the budget for each assessors workshop is about 2 million, and that translates to 17,000 USD. And if we are to have 6 assessors workshops, then we require a total of 102,000 USD, and this translates to at least 12 million Kenyan shillings. So we are in the process of lobbying for M&A for support from MNH MPDSR partners because we need these files to be assessed. On the progress in the implementation of the first CMD recommendations, specific sessions for discussions on the progress on the implementation of the first CMD report recommendations, this has taken place, and this we've done in detail this morning. We have discussed this. And we have to acknowledge that we have progressed so well after with the recommendations for the first report. And we also have published, we have a blog, and there's a case study for wide sharing. This emanated from this first CMD report. On integrating MPDSR activities into routine QOC and MNH accountability mechanisms, as part of the sustainability of MPDSR activities at the national level and the county level, the MPDSR technical working group members will lobby for the integration of MPDSR activities into the annual work plans by county and national levels. This is already happening. I'm sure this is happening at the national level, and of course the Transforming Health Systems, that is THS, funding also supported counties to have this in their work plan. So this will also ensure the activities are included in the QOC MNH accountability frameworks, and also integration of MPDSR in pre-service training of healthcare workers. Looking at the pros and cons of CMD and MPDSR, for MPDSR, it is conducted by health facility staff who took care of the woman who died. And there are difficulties within MDSR teams to critically review these deaths. And evidence has shown that multiple components such as facility audits, development of local leadership, and training of health providers is likely to reduce inpatient maternal mortality in district hospitals and slightly improve quality of care. This is by Wilcox et al. 2020. However, conducting death reviews in isolation may not necessarily result in reduction in mortality. Maternal death audits may need to be implemented as part of an intervention package, which includes training of a senior doctor specialist, a midwife in each hospital, and annual recertification and quarterly outreach visits by external mentors to provide point-of-care supervision. And this is also from that study recommending that. For CMD, this is independent multidisciplinary anonymous investigation. So there's lack of standardized methodological definition of how to conduct a CMD process. And some studies have shown that there's usually confusion in some quarters between MPDSR and CMD. So countries in low resource settings have set up CMD processes with lessons from the UK CMD process. And implementation approach for each country are different and deviates from the UK implementation model. While all maternal deaths in the UK are reviewed and action taken to improve care and reduce preventable deaths, for resource-limited settings, not all maternal deaths are reviewed because of poor record keeping. You will find that sometimes you have missing files, poor record keeping, maybe the notes are not complete. So what do we do about all this? And this is our way forward, that MPDSR and CMD are important because they complement each other. WHO recommends the production of annual MPDSR reports. We had our first annual report, 2019, and we are hoping to have our second very soon. UK and South Africa produce their CMD report every 3 years. For Kenya, we recommended that we produce these reports every 2 years. And there are discussions ongoing on the review of the MPDSR guidelines, as well as the MPDSR training packages. So just to emphasize that MPDSR is a postmortem of asking why did the woman die. Integrating the MPDSR activities into routine QOC and MNH accountability mechanism of MOH is critical, because in most of the MPDSR audits, maternal death audits, in the recommendations, we find that it is, the reason why the mother died, it was because of substandard care. So if we are able to integrate these two, maybe we'll be trying to take care of the quality of care aspect in the recommendation. As part of the sustainability of MPDSR activities at the national level and the county level, the MPDSR technical working group members will lobby for the integration of MPDSR activities into the annual work plans by county and at the national levels, and this is ongoing. And also sustainability of the CMD process is a major challenge, but this will need a concerted effort and pooling of resources between the MOH and development partners, as well as implementing partners. So there's still so much work for MPDSR. We've made great progress with support from LSTM and other partners, and we hope to continue with other partners in the same way, and maybe even come out stronger. And with that, I would like to acknowledge all the institutions who are presented by the logos outlined there. And I think I'll Photoshop myself to be fitted in that, in this photo. Thank you very much.
All right. Thank you very much, Madam Scholastica. We really appreciate your presentation. So we are basically coming to the close of the meeting, but before we conclude, we have one pending activity. That is, we are going to have a panel discussion And this is the opportunity to clarify a few final things and maybe field some questions to the panelists. So we'll start with the first participants in the first panel. It covers MPDSR and the in-service work. And the participants, as I call out your name, please come forward and take a seat. So first of all, we shall have representation from the Ministry of Health. Madam Helen Mutsi, you are representing the ministry. Please take the podium. On behalf of the 3 program counties, we have the following representatives. From Uasin Gishu County, the County of Champions, we have Mr. Richard Cheserek, the Director of Administration. Please come over, Mr. Cheserek, and take your seat. For the County of Culture, Vihiga County, we have Madam Veronica Musega, the RH Coordinator. Please take your seat. And for the other project county, Garissa County, of course, long-serving RH Coordinator, Mrs. Fatuma Iman. Please take your seat. We also have another implementing partner from the DESIP program, Madam Sylvia Wamuhu. Please take your seat on the podium. Now I'd like to hand over to my senior, Dr. Okoro and Madam Wangui, to take over this, to take the panel forward. Thank you. Karibu Wangui and Dan.
Good afternoon. Good afternoon, everyone. I think this is usually the hardest session. We've had 2 days, a lot of information, a lot of discussions, and this panel sits between us and the wonderful Nairobi traffic. So we've got a very powerful panel before us. They're going to energize us with some of those pending, those lingering questions that we've been having. And I think I'll challenge us to be keen on what they say so that we have a very vibrant question and answer session after this. So if you'll allow Dr. Okoro and myself to proceed, I am Dr. Wangui Muthigani. I represent USAID in this forum, and I'll give Dr. Okoro a chance to introduce himself as well.
And I've been introduced. Okoro Dan is my name, from UNFPA, and happy to join you once again this afternoon. I hope you are going to enjoy the session, as Dr. Wangui has already mentioned. So we are transitioning to transition from the national, the counties. And so, Dr. Wangui, what do you have at the national level?
All right. Helen, this is for you. And I think we've seen the tremendous support that the national level has got from FCDO through LSTM. So here, based on your national technical oversight role in maternal and newborn health services, how has this program linked training and practice?
Okay, thank you so much for the question. We've had high impact interventions. For example, the EMOC mentorship, whereby we are looking into having skills labs at all health facilities, performing a skilled birth. And remember, according to our Kenyan health system structure, skill delivery is done from level 2 up to level 6. So as national, as Ministry of Health, we need to have skills labs at every facility that is doing a skill delivery, and this one is going to improve on the skills, attitudes, and knowledge and competencies of the healthcare provider. And also, as also scholar was alluding to, the issues to do with MPDSR and also the CEMDs, those are the tools that evaluate the quality of care in terms of maternal and newborn care. If you look at the MPDSR and CEMD report, most of our mothers are dying because of the third delays. And what are the third delays? They come due to the skill of the healthcare provider, lack of supplies and equipment. So the ministry has seen the need for us to be able to improve on the quality of care for this mother and the newborn. We need to equip the healthcare provider with skills and competences. So the MPDSR systems will always be in place so that they are able to evaluate and to monitor how is our performance at the facility level. Which type of, which quality of services are we offering our mothers by looking at MNH, that is maternal newborn health indicators in terms of maternal mortalities, perinatal mortalities, ANC attendance, and other indicators. Thank you.
Thank you, Helen. And that brings me to the counties. And congratulations, Garissa. Congratulations, Vihiga. And congratulations, Uasin Gishu. Great performance and excellent. You got double awards. One was presented somewhere in the morning, and another one, time ya ugali, which I missed. Thank you so much. And we've had the 3 presentations earlier on, and even over the last 2 days, we've had great performance and great things happening. And as they say sometimes, what is this one thing that you pick, which you can be proud of and say and explain that this has worked well for us at the county level? We have got the pre-service, in-service. Of course, those are probably in the training at the pre-service, but many of your counties also have the level 4, 5 facility, which also have got KMTC around them, and trying to see how do those match with your service delivery. And you also have the MPDSR and MONC mentorship. What is this one thing that you picked, worked well for your county? Just explain to us. I start from, and say the champions. So we start from champions. Yes, Sarah. You have a mic?
I think what has worked quite well for us, and especially Uasin Gishu, is the ongoing or the staff mentorship that began with the program, and the training and the skills the staff received really boosted the services, quality of services at the health facilities. We have proceeded as a county to ensure that equipment is put in place in most of the facilities, and the county has supported. We have had our budgets factored in the annual work plans, our CIDP, and we have had, yes, implementation of the same from level 1 facility, level 2 up to level 5. In fact, currently we have a new partnership with the Israeli government that is going to equip about 25 of our health facilities, the labs. And by equipping the labs, we know diagnosis will be made promptly, and mainly from the ANC level and throughout to the fourth ANC, we'll be able to monitor our mother as well. And we have, additionally, we got utility vehicles to support supervision by our program officers to the facilities. At least we have a number of staff that the county is going to employ. And this is going to push much of the services. We have a very good referral system, ambulance referral system. And so that this is going to sort out the issues of delays, especially in referral cases. As a county also, we have, maybe I go to the down there, we have a health bill that is about to be approved by the county assembly, where the FIF money, Facility Improvement Fund, will go back to the facilities at 90%. So all the basic supplies that missed, issues of mentorship, including staff teas, will be very available in Uasin Gishu health facilities in a short while. We also have other expanding services. We'll be expanding theaters and equipping for CIWA level 4, Turbo, and the Capiteldon Health Facility. So we think that moving forward, will not be behind or like the 3 years that we were.
Thank you.
Coupled with the support of these partners, we hope that we will move forward and improve our indicators accordingly. Thank you.
Thank you. Thank you. Thanks, Raman. That means you're talking about the whole health system. Why even the county and engaging other partners to support the referral mechanism, expanding service access, amongst many others. But otherwise, you picked among mentorship was like the seed, which end up being catalyzed to generate all this support. Thank you so much, Sarem. And now, next, to the County of Culture. Yes.
Good afternoon, everyone.
Good afternoon.
Okay, my name is Veronica Musiega. I'm a midwife working for Vihiga County. And what I can say is that apart from the mentorship that Uasin Gishu have mentioned, we have actually done very well in mentorship. And I can say even up to this week we are sitting here, all of my sub-county mentors are actually doing mentorship on newborn resuscitation. So we decided that we will be tackling one particular EMOC function until we are sure that everyone is also almost becoming competent before we shift to another particular function. So apart from mentorship, we have also done very well in MPDSR. And for MPDSR, I can say that LSTM started helping us learn how to sustain ourselves by introducing us to the co-funding mechanism, where we, sometime in around 2018, we had a co-funding MPDSR training together with the LSTM, where Vihiga was catering for the participants, and the LSTM catered for the trainers and maybe the logistics. So from there, all through, we've always had in our annual work plan, MPDSR is part of it, and it is part of the annual work plan, and it is planned for all the way from community, to the facility, to the sub-county and the county. And all the committees have been put in place, and they are all functional. Maybe apart from the community one, they will only meet and when there is a death at community level. However, I know it rarely will occur. But at sub-county facility, we will always meet and on monthly basis, and the reports will be submitted. And this has really helped, and even the actions we are talking about here, the response they are, we really try as much as possible to be able to actually respond to what has been found out to be the gap that actually happened. Even up to the other day, we were even discussing on issues. Sometimes when we realize that actions are not being implemented, sometimes we have to push by force. So when we realize that maybe in our maternity the other day, the last quarter, October, November, December, we had an MO who had serious skills gaps, and he was not very willing to be mentored. So we had even to push up to our leadership level, who are very supportive, and we all had the MO even maybe deployed elsewhere until he's able to learn on issues of maternal health and be competent enough to come and work in our theater and even in our maternity. So we have done very well on MPDSR and really following up on the actions. Then again, as part of the actions on MPDSR, we've really tried to ensure that our skills labs that is at sub-county levels are almost being put into place. And thank God for some of also our partners. They've helped us acquire some of the equipment, like the Mama U, the Mama U, the Mama Bathi, and the neonatally, which are the key components of the skills lab. All our sub-counties have gotten. 2 sub-counties have identified the skills lab and placed the equipment in the same. And even last week when they were doing mentorship, they were actually using the same equipment and also using the skills lab to actually perform the procedures. And we've extended to other facilities just apart from the main facilities at sub-county level. Thank you.
Thank you so much. I can see the good culture of mentorship and also an MPDSR going on very well. And thanks a lot also for introducing yourself as a midwife, and we can see. Vihiga is my neighboring county, and it's neighboring in many ways, and I know it's densely populated. So even by contact, you can just pass the skills. Anyway, on a light note. And thanks a lot to the co-financing from the governor. I think LSTM started winning them. Is it too early? Or you have winned them for a long time? Yes, because for 5 years, 2018, or 2019. Okay, yeah, CBC, so you are now getting mature, so it's great. Garissa, Fatma. What's happening that side?
Garissa, good afternoon, everybody.
Good afternoon.
I'm Fatuma Iman. I'm a nurse midwife. First of all, I'm very happy to talk about Garissa today. Once upon a time, there was a time Garissa was not even in the national data. But today, at a blink of an eye, from Nairobi to Garissa, our data is visible. So that's a good milestone for the northern region, especially Garissa again. So Garissa County has an active MPDSR and EMOC training mentorship schedules with support from LSTM. I will never forget LSTM again, because the first time LSTM came to Garissa, when it was starting with the 5 provincial hospitals, Professor Charles is here. I was nominated to go and do a TOT training in Embu, but I couldn't go because my firstborn was doing her class 8 exams. Then I wait, this is TOT, this is my firstborn. Then I said, please, will you consider me another time so that I keep my daughter company? And today I'm proud to say my daughter is a registered nurse. She's a nurse midwife, working in one of the sub-county hospitals in Garissa. So by and large, that is how LSTM is known in my house, leave alone in the county, even my. So we have scheduled mentorship programs for 5 sub-county facilities, that the referral hospital and the 4 sub-county hospitals. Those are doing very well. The referral hospital had at least some problem with space, but luckily enough, my team from LSTM have shown in their presentation. The other thing is now, I am proud to say again, we are moving from 5 facilities to 54 facilities for MPDSR and a mentorship of EMOC through the support of an upcoming program with UNFPA. So clap for Mr. Dan Okoro and the UNFPA. I'm getting a new baby to support us. So, however, the challenges we have is Garissa is neighboring many counties. We get referrals from Kitui, from Tana River, from Isiolo, from Wajir, and the biggest refugee hospitals, which are 3. So whatsoever we do, the other thing we have is the high staff turnover, which we are trying to handle by making a retention package for our staffs through the dashboard. However, we are somewhere proud to say that we are moving ahead to minimize or reduce maternal mortality and improve maternal health. When it comes to skills lab now, I talked of 5, but we are also having an upcoming central skills lab which will be hub for the northern region, Wajir, Mandera, Garissa, Isiolo, Marsabit, through the support of UNICEF. We have received the equipments. We have identified a resource center, a room which is big, and things are underway. So we can even call people from Nairobi to come to our skills lab to use it as an IGA.
Okay.
We have, I said, of the small hospitals, there's the dedicated rooms, and the mentorship is going on. Even today, I saw a sub-county hospital, they were doing something on removal of placenta. When it comes to the dashboard, as I said, whenever we go for support supervision, we have our diaries and we check how many facilities, how many staffs, 2, how many are trained. So we just keep on balancing who is trained and who is not trained. When it comes to funds now, we cannot all the times depend on partners. The good thing with Garissa now, we have the previous governor. Our first governor is somebody who has passion for maternal and newborn health. And he has promised this financial year, he wants to build a MNH complex facility with theater and everything from MCH to theater and newborn unit, which will now give our staffs at least to work under one roof. Then we have fully implemented the CMED recommendations in the county. The other thing we have is the neighboring counties, I've talked about them. We have, except from the county referral hospital, we have 4 peripheral sub-county hospitals, of which 2 of them, the theaters are functioning well. We have 2 sub-counties where the theaters are not optimally being utilized, and there's a plan to make them 100% fully operationalized.
Okay, let me put you under pressure.
Yes.
Yes, I know you're used to heat, but this is now soft heat.
Yeah, so I think
Garissa,
in a nutshell,
yes.
that is what we are doing.
Garissa is according to the 2019 census report, which analyzed the latest maternal mortality ratio, which is acknowledged by the Ministry of Health so far. MMR is the highest. What is it that should be done? We are transitioning.
Yeah.
So how do we transition by pressing that 670 or coming downwards?
We are not
What
at
is this one thing that we should do?
We are at 631 now.
631?
Yes.
Okay. But it's among, it's actually
yes,
the leading.
we are among the worst. We were at 644, then we came to 641 now. As I said, the most contributory factors are our referral comes from very severely ill patients come from our neighboring counties. But however, even if they come as a facility, we are supposed to be ready for us to make those patients survive. So the plan I told you is to the building of the one-stop maternal and newborn health complex. Because our maternity has only 4 delivery beds, as I talked to you. That hospital was built, I think Helen has seen, and Charles, 1972. There is no infrastructure improvement which was done. So hopefully when we get this complex and we get enough space for our clients and even our health workers where they can have rest and do the work, I think with support from the new government and the willing partners, we are aiming to reduce half that number from 600 maybe to 300 with the hope of the assistance of Almighty Allah.
Thank you, Fatma.
Thank you so much, and over to you. Oh, go ahead.
Thank you. Thank you, Fatma.
I'm also proud to say she has passed Garissa County Referral Hospital when she was an intern. She's my new, I'm proud of her. Dr. Wangoi passed Garissa County Referral Hospital when it was a PGH.
And Fatma is like our mother, and we're so proud of the passion that she has for women's health. And I think as we're talking about maternal mortality, family planning is one of the key investments that any country or any society can take to reduce maternal mortality and to overall improve women's health and the economic development of our country. Now with us, we've got Sylvia, who is here representing DESIP. And maybe as we think about what is this DESIP program, she can start us off by giving us an overview of DESIP in Kenya. Thanks.
So thank you very much. As you've heard, my name is Sylvia Wamohu, and I am the DESIP director. She's mentioned about family planning, and DESIP is a family planning program funded by FCDO. Yesterday you heard that FCDO funds the largest family planning program in Kenya. This is it, DESIP, and it means delivering equitable and sustainable increases in family planning in Kenya. We focus on poor rural women, youth and adolescents, and persons with a disability. Indeed, we don't like leaving anyone behind, and there's just a general thinking that persons with disability don't have sexual and reproductive health needs, but they do. So we make sure that we also include them in our program. So DESIP works in 12 counties that used to have, I'm using past tense, because now we have improved with the new KDHS results, low MCPR of 45, less than 45%. But now we have seen, due to our work, other partners in the counties that we work, and of course in conjunction with the Ministry of Health, there has been a lot of improvement, and we're very proud of the work that we have done in the counties. So our focus has been to just ensure that women are aware of family planning. And just talking about the interlinkages, because you mentioned about the interlinkages of family planning and maternal health. And that is why I'm here today. I'm sure, of course, when you have family planning, we'll be focusing on maternal health. I'm very happy to be here today because we know that family planning is critical in reducing high-risk pregnancies and births. Why do I say this? We all know that we have cases of unwanted pregnancies. And when we have such cases, some people opt to take unsafe abortion, and that can lead to death. I wish they had taken a family planning method. We also have early marriages or early pregnancies. And the girls, we know that in Kenya we have teenage pregnancies. Their bodies are not exactly ready to give birth, and they end up getting into complications. So again, if they were aware of family planning, since they're already sexually active, I wish they had taken a family planning method. And of course, birth spacing. In the morning during the session, we heard that in some communities, some people do not want to take cesarean sections because they want to have 15 kids. If they were to space, maybe within the 2 years that is recommended, that would take 30 years to get the children, isn't it? So, of course, we would recommend, part of our work is to tell them, don't get 15, at least get 3 or 5. But you can imagine, if they don't space, that woman will be so frail in terms of nutrition, in terms of health, and even the babies that are unborn and the ones that are born, then they'll also be affected. So you can clearly see how family planning is linked to preventing maternal deaths. It is all about the work that we do under family planning, but of course, integrated with many other things. So getting a little bit into the DESIP work, just to show you how we come in, we start right from the bottom, whereby we go to the community level, then we think about the health facilities, and of course we work with the national and county governments. So it's a bottom-up and at the same time top-bottom. But very briefly, at the community level, at the beginning of the project, we developed social behavior change communication strategies with each of the counties that we support. We did this because we know all the counties are very different. What works in Homa Bay will not necessarily work in Wajir. And we use this to guide our intervention. We work with demand creation agents to implement those strategies that we came up with. And just to give an example, we really utilize the community-based distribution model, whereby the community-based distribution models go and meet the women in the houses. At the community level is where you meet a pregnant woman who is in their 3rd trimester. And this woman definitely need to take up an FP method after giving birth. Today, postpartum family planning is very important. Before that woman leaves the health facility, and we've heard from LSTM that they are really doing a lot to train these healthcare providers to offer high quality services. But can they also offer family planning at the point that they're leaving the health facility? So like when this woman comes to the health facility, then they have also moved to another stage whereby they can accept to take family planning services. So you make your work easier. You have a qualified healthcare provider, and we are giving you a woman who is ready to take up an FP method. Similarly, we have women at the community level who've given birth, but somehow they did not take up a family planning method at the time of birth. So we really talk to them so that they can go and take up the family planning methods. And also, sexually active women who are just confused, they don't want to get another woman, another baby, but at the same time, they don't know about family planning. Very briefly, about what we do at the health facility level, it is all about quality improvement, and this is where we train our healthcare providers on postpartum family planning. We ensure they have the right equipment, and very importantly, that the commodities are available. We also just use the same approach, structured mentorship, so that organically, these skills that we build on our healthcare providers can keep moving from one health provider to another. At the national and county level, it's all about policies, so that we can be standardized in our implementation, so that we can have guidelines and ensure that there's continuity and sustainability in our interventions. Thank you,
Sylvia. And I am really, it's music to our ears when you mention postpartum family planning, because it really gives that 360 care for women. Immediately you get a baby, the baby is alive and well, then you can advocate for PPFP. Or ideally, you should advocate for it at antenatal care clinics. But now that we talk of the wellness of the baby, there are times when we get perinatal mortalities. Veronica, briefly, could you walk us through Vihiga County's experiences with perinatal death surveillance and response? Thanks.
Okay, thank you so much. Okay, on issues of perinatal mortality, so sometimes when we have this perinatal death, many times these mothers will really be devastated, they'll really be down. So we have developed a mechanism where our providers are trained on actually just being able to debrief this particular mother on this actually what went on, so that she's able to understand how it was and be able to allow even just being part of the situation and letting her talk out and verbalize so that she accepts the situation. That is basically the psychological counseling. Then after that, on weekly basis, we will actually carry out the perinatal death audits. So we will have the maternity team, and that is the labor ward team, and also the newborn care team, and identify all the files that the babies that we lost. It could be a stillbirth, that is 28 weeks above, both macerated, and also the freshest bees, and also the early neonatal deaths. Those files are assembled, then the team sits, and we are able to go through, so that we are able to identify which are these areas that could have been improved. Like for the MSBs, maybe this mother came with the no-fetal heart, and you realize that maybe there were ANC profile there was a gap there. Could be she had issues with the not taking IPTP, that is malaria and pregnancy, could have possibly caused the death. Then such issues we actually will respond to the community. Sometimes we have a CHA as part part of the committee so that we have that response at community level so that they are able to ensure that they be default at risk women who have not had IPTP and not sleeping under the net and be able to actually have the interventions at that level. If it is issues of newborn resuscitation, as I said, maybe that is where the gap was. As I told you, even up to last week, we realized we had lost quite a number of mothers, and from sub-county level, we could see 3 were from the sub-county asphyxia, another 2 from the sub-county asphyxia. So our mentors were now mentoring on newborn resuscitation. And before we came here, we actually called all the mentors and updated their skills on issues of newborn resuscitation before they actually went down to the providers so that they are actually offering quality mentorship. And thank God for the division. They had actually given us the modules for mentorship on like newborn resuscitation, and we have a checklist. So we use the checklist as somebody is actually performing the procedure, somebody is marking the checklist, and any provider that gets like below 85, then we have to redo it again because maybe the skill has not been acquired. Then the MP, after, when we are doing the MPDSR again, we normally have an HRIO who is seated and taking the notes and actually uploading the same on the system. However, I think they've had issues with the KHIS system because they've always told us we've always uploaded all of them. But you realize that some of them, we can't see them on our end, so we have gaps there, maybe which we really need to address.
Thank you so much, Veronica. Allow me to hand over to Dan.
All right, now we are grateful to the team that has shared with us their experiences from their practice and the observations. Thank you so much, Sylvia, Fatima, Veronica, Helen, Sarem, for the great and wonderful work. Help me appreciate them. Yeah. I want to show you something. Before I came to Nairobi, you know, there was this where I came from the village where the pyrethrum has not been discovered how it works. So you know how we kill the mosquitoes? Yes. So you see that the mosquito is just moving around, isn't it? So you try to, okay, just do like this, yeah, just do like this, and catch it. All right, confuse the mosquito, confuse the mosquito. Thank you so much. Yes, I came from the plains of Kano. Thank you so much. So we call the next.
All right, so yes, we are almost at the end. We just have a small, a short conversation again on the pre-service training, where we have representation from KMTC. We have Mrs. Catherine Waigwe, Head of Nursing Department at KMTC. Nursing and midwifery. Please come forward. Second, from the University of Nairobi, we have Dr. Kanini Matheka, Head of Midwifery Department. I believe it is School of Nursing and Midwifery. From Moi University, we have Dr. Dina Chelangat, Dean, School of Nursing and Midwifery. Most welcome, take your seat. We will have a brief conversation too. And finally, last but not least, Mr. Ibrahim from the Clinical Officers Council, are you around? If not, so the regulator is missing in action. So I think Dan and Wangui, please take it forward. We have the 3 panelists here with us. And while at it, Mr. Cheserek from Eldoret, please raise your hand. He has misplaced his bag. I think it is the event bag. If somebody sees it, please just pass it over to him. Thank you.
Thank you so much. Once again, we are in phase 2, the last phase, so don't get tired listening to these voices. They may be singing baritone, isn't it? And welcome. It looks like the ladies, the man has this, where is it? Where is, Commander? I thought it was there. The COC is not represented, Ibrahim. Okay, we'll proceed with the team here. I believe you will be able to share on the experiences. You've heard what has taken place, what the counties are saying, what the Minister of Health has said, and what LSTM has given us, and whether the Minister in terms of the transition. How will your institutions, the colleges where you are, and other research institutions collaborate in capacity strengthening, providing those opportunities based on this program, which will contribute to improving maternal and newborn health. Maternal and newborn health. So the collaboration that your institutions will have alongside the others' research to improve maternal health. I start with Dr. Dana.
Okay. Good evening. Is it evening or afternoon? I want to say that we are very grateful for LSTM, who brought us in the middle. We got to be involved in what KMTC had been doing in pre-service training. And we are very grateful because I remember, I think I was trained by LSTM in 2013. And the then dean of the school learned that there was a training for midwives. And she said, no, we cannot be left behind. So actually, I got a chance through the Uasin County portion. We came with the Uasin County, not because the school had been invited, but I got the opportunity to be trained together with a pediatrician because we felt that we needed to be at par with what is happening in the counties. And I really appreciate of all the trainings that I've ever gone. And as I say, my age is, I'm not young in the profession. A lot of trainings I have gone to seminars and workshops, but none like the one of LSTM because it was hands-on and it is hands-on and it should be hands-on. And so I really appreciate the training. Out of that training, it has been of great help because in the Department of Midwifery and Gender, which is one of the departments at the school, we are 4 departments. I think 50% of us have been trained in LSTM skills, updates, and the head of department is here. He can prove that. But I want to say the students have really benefited a lot through the training that we have received because we have skills lab. Since we started a collaboration earlier in 2000 with another team, we were able to get some skills lab, but we did not have enough time or a scheduled way. So after the training in LSTM, Dr. Lydia Mwanshia, who is now working in LSTM, really took up immediately and was able to put what needs to be done in the midwifery skills lab. And I want to say those who came for the training last year in February were able to see our midwifery skills lab is fairly, we are not saying we have everything, but we are fairly equipped to be able to prepare the students before they go to the clinical area. Because we believe in evidence-based practice, we are also doing research to be able to inform practice, and we try our best to work with the team from the hospital, and as we have been in our discussions upstairs, we will never, as health training institutions, do the job we ought to do when we are out of hospital. So we have to be in the hospital, we have to partner together so that whatever we are teaching the students from the school and in the skills lab, they get the same in the hospital, and therefore, with us from the Mo University School of Nursing and Midwifery, we are working together with the nurses from MTRH, with other teams of nurses from outside to do research to improve practice, and therefore, I want to say through LSTM and other partners, we are preparing our students better for the practice, and we, as LSTM exists, there is a plan which is an advanced stage to make Mo University part of the centers that will be providing CPD points for midwifery educators every 2 years. And so we look forward to that, because we believe with that we shall continue getting updates. Thank you very much.
Thank you very much. Thank you very much. Thank you very much. And Charles, you can see it. You made it happen in Garissa, and you're making it happen again here, 2013, 2017. And yes, Catherine, I know you cover the whole country, KMTC. When you mentioned KMTC, it's everywhere. But specifically now, how research collaboration with your institution, and as far as this program is concerned.
Thank you for the question. As you said, KMTC is a big baby that has been born everywhere you walk. We have 51 campuses, and take this from our strategic plan, because it's at that point, we are at that point where we are reviewing our strategic plan. And the strategic direction in terms of KMTC research, collaboration, and consultancy are actually the key that we look at. And for us, that then, when we talk about what has been happening, we have been the biggest beneficiary, obviously, of this collaboration with LSTM, coming from the point of that addendum that we did. And then we were able to bring it up, and now we're able to train. And now we're looking at what we have achieved in a very short while. We've been able to look at, because you have to use what you have, the lessons that you have learned. And of course, when we're talking about curriculum, this curriculum review that we are continuously doing, again, informed by research and audits that are done here and by. And actually, last week we were able to we started the review of the Kenya Registered Nurse Midwife curriculum, which we did our needs assessment, and now we are able to collaborate that. To bring in that and collaborate with our stakeholders who are supporting us in terms of MNH. And the other thing that is very key for us, we are able to put the budgets in place as we're looking at our strategic direction. We are able to fund, and now that we have incorporated EMOC as a requirement, is a module in our curriculum. So it is no longer that we may think about it, now it's mandatory. And therefore the resources to be able to support that have also been put in place. And we have also, as I think somebody alluded earlier, we are required to have 20% in terms of the training as on e-learning. Again, we have resources that have been put up so that we can be able to incorporate this and put it on our platform, so that our students can be able to get it and be able to get the same knowledge all over the 51 campuses. And then the other thing that we look at in KMTC is resource mobilization, whether for research or whether for other activities that we have. And we have developed a team for resource mobilization to be able, one, to look at what are the needs and what are the gaps in our training, so that they can be able to look for resources that can be used to provide that and to cover the gaps. And I also want to talk about when we are training the midwives, it has now become a requirement that when we are doing our case studies, our students are supposed to pick a case and be able to follow through, so that they can be able to use it as a learning tool. And so that, again, we have taken it up and we are making it mandatory, that when you do your midwifery care studies, you are able to go out and you're facilitated to get out there and do this care study and come up with results.
All right.
part of what we are doing.
Thank you. Thank you so much. Quite great opportunity in strategic plan, establishing the KRNM, and among many others, including resource mobilization for research. So research is at the center of at KMTC. Yes, Dr. Kanini, from the university. I don't know whether it still has the D or it's a university, but here you are. Karibu sana. How does research play? What is the place of research as far as this program is concerned in collaboration with University of Nairobi?
Thank you. We are still the University of Nairobi. And regarding collaborations and research, as far as this program is concerned, is that we are really, really grateful as a faculty, as a department, because of what LSTM has done. Because through the collaborations, we've had several faculty trained on EMOC, and also we've had our curriculums updated, especially in the field of midwifery, and we are really grateful for that. Now we intend to continue doing collaborations with other organizations and with other institutions, particularly the training institutions, so that we can ensure that our students continue to have what we call skill-based training, because unless they have those skills, then it means that they cannot be able to perform well out there. And now regarding that, we have to ensure that our faculty are well trained. The faculty that were trained by LSTM, they have, a number of them have gone to other institutions, but we still collaborate with them and we consult with them. And the good thing is that they even mentored others in the institution, and we continue to benefit from that. So going forward, we intend to utilize those skills so that we can ensure that our students are well prepared and ensure that the output is good. Now, regarding collaborations with other institutions, particularly the clinical areas, we intend to continue going forward, getting in touch with the qualified midwives and obstetricians in the clinical area, so that we may have updates on what is happening, and that will ensure that our faculty are updated, and also it will benefit the students. And of course, research being one of the core mandates of the university, particularly even what LSTM has done is we partnered with them in doing some of the researches, and we intend to continue moving forward to do research, even with the other partners and other organizations as well.
All right, thank you so much. And maybe one last question from Dr. Wangoi.
So thank you so much. I know with lecturers there, if you give them a chance, they'll give you a full hour of their time. So for our final question, I'll ask each one of you to give one takeaway as academic institutions in terms of the learning and the evidence that we've taken from the pre-service component of this program. What would be one key takeaway in as brief? Yeah, thank you.
Now, one takeaway that we will adopt for the University of Nairobi is that we will continue using the updated curriculum on the line of midwifery and reproductive health, because from the look of it and from our experience, it's a good thing, and it's benefiting our students and the community at large out there. Thank you.
For us, we learned a lot in terms of improving the confidence level of our lecturers and building their knowledge. And one of the key things that I picked is that mentorship sustains that. So that is what we are going to take away from this. We'll continue to mentor our lecturers.
So the takeaway that we go back home with from here is, from the research that was presented, lecturers are very confident and they are so knowledgeable as far as the theory is concerned, but the practical component of training is limited, and therefore we will put more efforts to ensure that our lecturers do practice the EMOC that we have been trained so they can be able to impart the same to the students in the skills lab and also in the wards. As I had said earlier, the clinical aspect of training is key. Thank you.
So thank you very much. I think those are very powerful takeaways. Mentorship, increase the confidence of your lecturers. And I mean, when your lecturer knows, then you're confident that our health practitioners will also take on the skills. So I think at this juncture, we need to appreciate our panelists. And because Dan knows so much about how to appreciate people using various components in our environment, I'll hand over the baton to him. And thank you very much.
At this juncture, I will abstain. Isn't it? Let's appreciate our panelists with the Nyayo. We used to have someone called Nyayo. Isn't it? Yeah, so those who have lived those ages can know. Karibu, karibu, karibu. Nabanda kitingiza kidole sasa. Sorry.
Okay, thank you very much. In the same vein, I think we sincerely appreciate Wangoi and Dan for a job well done. So let's also give them a round of applause. So thank you very much. Thank you all for the really good participation, the good engagement, the many discussions, including those who are watching us online. I think it has been very fruitful 2 days. And as they say, whether good or bad, everything has a beginning and an end. So we must come to the conclusion of this conference so that we can take forward the things that we've agreed on, the things we desire to do for our country. So at this point in time, to wrap up and close the session, I would like to welcome our program director, Professor Charles Ame, to do the wrap-up session. Welcome, Professor.
Thank you, colleagues. It has been a very exciting 2 days. I know we're probably 75% population left in the room from where we started, but we make allowance for the VVIPs who could not stay for the 2 days. But this has been a very informative 2 days. You will agree with me. And at this stage, I speak with mixed feelings. I remember the first time I went to Garissa, and I met Fatima, and she showed me around. So from that time to now, she's one of the longest serving RH coordinators. All we have achieved together throughout this program. We started from doing some of the routine things, EMOC training, changing the way EMOC training was done, moving it into pre-service, and looking at various ways to improve the quality of care, but trying to embed a sustainability component. So I feel that as we come to an end of this, to the end of this very exciting program in Kenya, this program, I see it as made in Kenya, owned by Kenyans, and will continue by Kenyans. I think those of us who come and go, we're just passers-by. And I think it's up to you to, carry things going forward. Much has been achieved, lots more to do, but I think we have laid the groundwork to be carried forward by our partners. Our engagement with the counties and with stakeholders over the last 1 year through the KMLs, the knowledge management learning events, co-development of the sustainability plans, we have identified additional areas where you need our support. As LSTM, we are keen to take forward all the learnings. We accept the challenge to focus on difficult areas in the country around maternal and newborn health. And we will engage to ensure that effective innovations are backed by policy at various levels, because this is crucial for sustainability. We welcome you to continue engaging with us. We are pleased to share all our experience, our knowledge, our tools, and we are keen that those of you who continue implementing M&H programs, you do not make the same mistakes we have made. You learn from our experience so that your programs will even be more effective. Our sincere thanks goes to the government of Kenya, the counties for the warm welcome and partnership. Special thanks to our funder, FCDO, the people of the UK, for the opportunity to serve the women and the newborns of Kenya. So what is next for LSTM in Kenya? We're still present in Kenya. We still have programs going on in 3 of the counties we currently work in, really looking at improving the quality of antenatal and postnatal care, including postpartum family planning. We're also involved in several research pieces around antenatal care, really trying to answer the question of how do we achieve these 8 antenatal care contacts in a way that is effective and can really improve the health outcomes. We have developed a pre-service MPDSR curriculum for midwives in collaboration with the Alliance for Improving Midwifery Education, which is a global think tank led by UNFPA Sexual and Reproductive Health branch in New York. Kenya is of great interest to LSTM. We have a team based at Kisumu, led by Professor Faiko and Professor Penny, doing a lot of work in malaria and pregnancy. We have several grants with that team, so we're still here for a long time. Our team in Nairobi continues to work on the grants we have. LSTM as an organization, 125 years anniversary this year, has identified Kenya as one of the 6 hubs, global hubs that we want to really establish and expand. And Kenya is in the first phase of those hubs. Like I mentioned earlier on, LSTM has over 400 alumni in Kenya, and we want to really, bring out our alumni to help us collectively, achieve some of our ambitions in Kenya. The mission of LSTM really is about trying to improve the health of people in disadvantaged populations, and mainly doing this through research and education. And this will continue to be our approach. Our approach to education, is changing. No thanks or thanks to COVID. The way we will have our educational offerings will change. You don't have to come to Liverpool to get an education, a master's or a PhD. You can get it here in Liverpool, in Kenya, to the same quality. So lots of exciting stuff still coming on, so LSTM will still be around. I want to use this opportunity to thank all the moderators and facilitators of all the sessions over the last 2 days for doing a stellar job, so thank you so much. For our team in LSTM Kenya, we're just a small family, and I think you guys do an awesome job. It's been challenging, everybody works so hard, and I think it's just been an incredible 2 days. Near faultless. You all know me how I critique you so much, but I cannot find anything to. Even the temperature in the room is perfect. So I think you've done an outstanding job. So just to conclude, I wish you all a safe journey back to your various homes and your jobs, your families, and we will still be around. And before long, I shall be eating ugali. Somebody has promised me. I have not been offered the right one, so I am having my fingers and toes crossed for that one. But thank you so much. It's been wonderful having all of you, and wish you all the best. Thank you.